Good morning, everybody. I think today is a very exciting day. Not only is the sun out and it's much warmer than we would even guess, but it's really the day of getting today from the highest level experts in the world an idea of the treatment landscape for both NF2 and Schwannomatosis. I'm going to keep my introduction very short because I have very prominent members and friends who will speak and give you a quick introduction. What I just wanted to say is please put all your questions in the chat. And the next thing I wanted to say is that at the end of the day, we're going to hold a brainstorming session. So if you have ideas during the day and you're worried to forget them, please put them in the chat so we can keep a document that we can already start using for the end of the day. But with that, it is my absolute pleasure to introduce a dear friend and somebody who is the Medical Advisory Committee Chair of the Children's Tumor Foundation. His name is Wade Clapp. He is the Chairman of Pediatrics at Indiana University, Physician-in-Chief of Riley Hospital for Children, and then he has a long list of other glamorous titles, but I'm just going to say, take it away, my friend Wade.
Thank you so much, Annette, and welcome everyone. It's great to see a lot of friends on the screen, and Annette has really planned a fantastic day. Obviously, the reason that we're
recording in progress.
Obviously, the reason we're all here is because there's a tremendous need for new drugs and therapies for patients with neurofibromatosis type 2. I looked back, and when the first drug became available of any kind, and it was a fantastic breakthrough by Dr. Plotkin, published in the New England Journal of Medicine, bevacizumab, and that was July of 2009. Our next significant shot on goal, I think, has been brigatinib, which is a multi-tyrosine kinase that is still currently in clinical trials, in an initial clinical trial. We obviously need to move faster and move more effectively. And I think the panel that in the program that Annette has superbly recruited, focusing on from current therapy to gene therapy to biology and future targets and models over the course of the day, provides a great stage for us to sort of review where we're at and to begin to make strategies to move forward at hopefully a much faster pace than we've made up to now. We clearly, for our patients' benefits, need to move faster than having one new drug shot on goal every 12 years. So I'd like to, with that brief sort of charge to us all, I'd like to turn it over to Dr. Marco Giovannini, our good colleague and truly a world leader in this space from UCLA. Marco?
Good morning, everybody. Happy to be here today, and I will share my screen so you can see I have a single slide. And yeah, it's exciting to be here today, and it's only 7 a.m. in California, and I know we're spanning many time zones from the US to Europe. So good morning or good evening, everybody. This meeting comes at a very important time, and the message that I want to make with this simple single slide is that this is timely in my view, because it comes when a new updated nomenclature for neurofibromatosis type 2 and schwannomatosis is being proposed. And the initiative was led and coordinated mainly by Scott Plotkin and Gareth Evans in a collaboration with several colleagues, members of our field. What is important, I think, is that schwannomatosis is now the umbrella term, which includes both neurofibromatosis type 2 and what we called before schwannomatosis, since they both share the genetic predisposition for schwannoma formation. This has yes.
Are you meaning to share a slide?
I thought I was sharing a slide. My apologies.
Now we can. Thank you. Great.
Yes. So I borrowed this slide from Dr. Plotkin, and it summarizes what I was just saying, that schwannomatosis is now the new umbrella term for both NF2 and schwannomatosis, and which has important consequences because now molecular analysis is clinically indicated for all patients suspected to have schwannomatosis. And also there has been a revision of the names of the single entities. So what was neurofibromatosis type 2 before will now be NF2 related schwannomatosis, and SMARB1 related schwannomatosis, LZTR1 related schwannomatosis, 22q related schwannomatosis are now declinations of what before was simply referred to as schwannomatosis. So why I think this is so important? The fact that we now recognize that all share this genetic predisposition for schwannomas formation, in particular because biology and genetics points to loss of NF2 as the single most important and determinant initiating event for schwannoma formation across all conditions and regardless of the underlying germline mutation. Of course, this has important consequences because eventually we will consider both NF2 and schwannomatosis patients as candidates for clinical trial for new therapeutic approaches. This is where I end. Again, welcome everybody. Thanks for giving me the opportunity to participate in this workshop.
Great. So I think we move on to our next segment. And what are today's treatments? Drugs versus surgery versus radiation. Let the panel introduce themselves.
So I'll sort of start off by sort of handing it over to the other people in the panel. I'm Professor Gareth Evans. I'm Professor of Genomic Medicine and Cancer Epidemiology at the University of Manchester. And I've been working with NF2 and schwannomatosis since 1990. Did my thesis on NF2. And so it's my special baby, as it were. So I have huge enthusiasm for trying to make things better. So Scott, I think you're the next person I can see in the panel. We can't hear you. You're muted, Scott.
Apologies. Trying to cut back on the feedback. Thank you, Professor Evans. My name is Scott Plotkin. I'm a professor of neurology at Harvard Medical School, Mass General Hospital, and help run our NF Center here, and very interested in both NF2 and schwannomatosis and in developing novel clinical trial designs that allow us to screen drugs more quickly and to identify new active drugs.
And Brad Welling, I think you're next on my list.
Hello, Brad Welling, Harvard Medical School, Mass Pioneer and Mass General. I'm a neurologist, So I work on these tumors surgically, and I'm also very anxious to move this out of the surgical realm, see if we can't find a better way to give back protection against these tumors growing. Glad to be here today. Thank you.
Thanks, Brad. And Ros Ferner?
Hello, I'm Rosalie Ferner. I'm Professor of Neurology at Guy's and St Thomas's in London, interested in all forms of neurofibromatosis. But my particular interest in this session is with schwannomatosis, both clinical and looking at clinical trials.
Thank you, Ros. And Jayshree Blakely?
Morning. My name is Jayshree Blakely. I run the Neurofibromatosis Center at Johns Hopkins. I'm professor of neurology, neurosurgery, and oncology here, and participate in designing novel clinical trials.
And then I think Michelle Calamarides is next on my list.
Hello, I'm Michel Calamarides. I'm a professor of neurosurgery in Paris at Pitié-Salpêtrière Hospital. I'm running the National NF2 Reference Center, and I worked in the lab. I started 25 years ago when I was a PhD student with Marco Giovannini, working on mouse model of meningioma mostly.
And then I think Alan Belsberg. Can you turn your video on, Alan? Maybe he's gone to sleep. He's been operating all night.
He's actually still here operating.
He's still operating, yeah. Yes. Okay, well, we'll come back to Alan if we can later. But Alan, well, Jayshree, you can introduce Alan.
Dr. Belsberg is professor of neurosurgery. He runs the Peripheral Nerve Center at Hopkins and is a member of the Spine Center and is the co-director of the NF Pain Institute.
So that's
I can also answer all questions for him.
That's our panel to answer our questions going forward. And I think that the aim of this is to say what the sort of current treatment would be for different clinical scenarios and where we think clinical trials and our hope is that nearly all situations will be amenable to clinical trials in the future, the sort of trials that are being run with brigatinib, etc. So one of the things we thought we'd start with is just a little introduction to the different models and just a little bit of data to show how important having really well-organized NF2 specialist services are, because they can make a real big difference to life expectancy in the NF2 condition. So the reason I'm passionate about it is because we actually produced the first data showing that specialist centers, management in specialist centers was associated with better survival in 1998. And as a result of that, we were able to commission NF2 highly specialized services in England. We largely serve the rest of the UK as well. And so essentially the UK is managed by 4 expert centers. And then in the US, you've got 5 or 6 expert centers. Correct me if I'm wrong, Scott and Jayshree. But obviously the vast majority of NF2 and for that matter, schwannomatosis patients. So we have 524 patients diagnosed since 2010 and only 14 have died. You can see that a lot of those deaths are normal expected deaths in terms of life expectancy, and only 2 have been definitely NF2 related, with 2 of the younger deaths actually being due to cerebrovascular events and a question mark as to whether or not there might be some relationship with that. And survival is significantly better than the previous decade and also going back further. And if you look at, for instance, the mean age at death, you can see how much higher that is at 63 compared to...
On the webinar site, people cannot see the slides, Sharon.
Well, they can't see the slides. Can you see no slides at all?
So we on the webinar site.
Well, I'm sharing and I'm seeing it. Is no one else seeing it?
We see it here.
Just keep talking. We're working on the slides. Thank you for your patience.
Okay, so I'll just describe. So basically, a 20-year better mean age at death since the inception of the service, highly statistically significant. As you can't see, but virtually no premature deaths under the age of 75 related to NF2, and the overall survival. It's only 10 years, obviously, since the inception of the service, but I have to sort of enlarge it here to show you the difference in these curves separating in the first 10 years. But probably more importantly, the actuarial survival actually looks like a normal survival curve for people. Now, it may be, and I'm certainly going to thank, really is only one option, and that's surgery. So if you have a patient with NF2 presenting with a 6-centimeter tumor, vestibular nerve.
You mentioned the different specialists of the team. You didn't start with neurosurgeon. I'm very surprised. NF2 is a surgical disease. So at the end, you say neurosurgeon.
No, I'm saying there's no option other than neurosurgery for a couple of situations. So
on the list, I was the last. I'm not very happy, but it's okay. You started with genetics.
But you're the lowest on my list down the the faces. You're the one at the bottom. Wow. So I had to go through the ones I saw on the list.
Okay.
Michelle, honestly, he didn't mention neurootology.
Problem.
Yeah, sorry.
Okay. All right.
Problem solved, guys.
I couldn't see you either, Brad.
It takes a neurosurgeon.
Okay, so the problem is solved. Neurosurgeons can be back.
Okay. Garrett, you have the chance to do again.
Yeah.
We're doing
recover, Garrett. Recover this.
So I will just, for those that may have missed the end, essentially what we've been able to show in the UK with this highly specialized service with only 4 centers managing the patients within a 68 million population is a huge improvement in survival, and we feel quality of life as well. And I put a lot of that down to Scott with bevacizumab, but we do need alternatives. There are long-term sequelae of bevacizumab. It doesn't work in meningiomas, doesn't work in all ependymomas. The cystic ones, it works quite well. So I'm going to present a number of clinical scenarios that we're going to discuss in our clinical team. A clinical team of neurosurgeons, neurotologists, neuro-oncologists, neurologists, geneticists, and have I forgotten anyone else? I'm not sure, but I think that pretty much covers it. So we are presenting cases where there potentially could be different types of treatment used, either surgery or radiation treatment, or potentially drugs. But also what we want to emphasize is that in many of these situations in the future, we hope that these patients will be eligible for drug trials. And we encourage as many, obviously, as possible to go into those trials so that we do come up with more treatments. And we have a limited population, obviously, with rare diseases, particularly schwannomatosis. So there are 2 sort of clinical scenarios we thought we would just get out of the way, where there really is only one option. So someone presenting with a 5-centimeter vestibular schwannoma, compressing the brainstem with no hearing. And what would you do, Michelle?
I would recommend surgery.
Yes, I don't think really there is another option. So there are situations where there really is not another option. With a compressing lesion of the brain or the spinal cord, particularly presenting acutely, and we still see NF2 patients presenting for the first time with these lesions, we don't have another option. Radiosurgery is not an option. There is a limited size at which you can treat with radiosurgery because you initially get swelling And swelling is the last thing you want when you've already got a lesion that's massively compressing either the spinal cord or the brainstem.
The only point I would make is surgery, yes, but to avoid any facial palsy and lower cranial nerve palsy. So maybe not a total removal, and keep the function intact.
So in that scenario, obviously there is, with a partial removal, you are going to leave something behind. So there may be the option of radiation treatment or drug treatment for the remnants to try and control the remnants. But I think we're probably going to now discuss the sort of more straightforward scenarios where we're not really thinking about a partial removal and then further treatment, but actually the potential primary treatment of any of these tumors. So we'll start with a young patient, we'll say a 15-year-old with bilateral vestibular schwannoma, with tumors predominantly in the canal, but on the left side growing at 4 millimeters a year. So you can see on this scan, the right-sided tumor, which is the left of your screen, is quite tiny in the canal, and the other one is on the left side is just poking out, and it's growing at about 4 millimeters a year. So who would like to have a go at that one? Brad, would you like a first stab at that?
Sure, I would appreciate that. I think that it's important to ask how the hearing is in this young man, if he's got normal hearing in both ears.
So he's got normal hearing, we're going to say, okay?
All right. And for the sake of argument, I assume since we know that the left tumor is growing, that we also know the right tumor hasn't grown much, or we have some.
The right one is growing slower. We'll say 1 to 2 millimeters in diameter a year. Mm-hmm. So unfortunately, we're not in the 21st century and talking about volumetrics. So
that's okay. Well, so I think the point is that that there's quite a bit of disagreement among the experts on this panel about how this patient maybe should be managed or maybe should have been managed. And I would say that, if we went back a couple of years ago, both of these tumors would have been smaller. And if we had the opportunity potentially to take out the least intrusive tumor and potentially save the hearing, that would have been a good thing to consider. And maybe even now, still, it's a good thing to consider, particularly on the smaller right-sided tumor. The reason that I bring this up, and I know that a lot of people say, no, if there's no deficit and the hearing's normal, let's just follow them, is because I see a lot of older teenagers where the tumors are large enough that we really don't have much opportunity to save the hearing. And it's even difficult to potentially save the cochlear nerve with a total tumor removal as the tumor gets up next to the brainstem. And I think both Michelle and I have experienced where there are patients where we maybe don't save the hearing, but we do save the cochlear nerve intact, and then they can receive a cochlear implant. And we've talked about this, and they're not really great studies done. I will admit that the retrospective nature, there are just a couple of prospective studies done looking at cochlear implants in patients with NF2. But in our experience, we initially presented six patients 20 years ago who had their tumors removed, and we didn't save their hearing, but we did save their cochlear nerves and then implanted them with the cochlear implant. And over ensuing 8-year follow-up, 5 out of the 6 maintained their hearing, and they all had open set speech understanding, which is unusual. And in a bigger retrospective series, that's not always the case when a tumor is taken out and you put a cochlear implant in. Even if you think anatomically you've saved the cochlear nerve, only 50 to 60% do have open set speech. But when we do the alternative, which is to place an auditory brainstem implant, somewhere between 5 and 12% of patients get open set speech. So I think there is a risk to taking out small tumors that you may lose hearing, but there's a risk to not taking them out because you may lose the opportunity to put in a cochlear implant, which usually gives much better speech understanding than auditory brainstem implants do. And in fact, in retrospective studies, 80% of patients use their cochlear implants every day, 80 or 90%. With ABIs, it's not that high. Open set speech is much better. So I would say in this patient, I would consider taking out the smaller tumor, even though the other one's growing more, just to try to save the hearing in that right ear. If we did, then I think you could take out the the left tumor also and try to save hearing, but at least in the first year, you'd have an opportunity for a cochlear implant. Left ear, maybe or maybe not, probably could still save the cochlear nerve in that ear as well. Michelle's done some really nice intraoperative monitoring of hearing that I think is actually quite helpful with partial removals. And maybe, Michelle, you could talk about that because I'm trying to mimic your work there. I think that's been very useful.
I would just add, if the right is not growing, I would discuss surgery on the left, but I need to get the auditory brainstem response. If it's okay, I mean synchronized, the chance to preserve hearing are good because you can monitor the nerve and then you can add the monitoring of the cochlear nerve by putting a ball on the nerve. So if ABR is okay, I would discuss surgery. If ABR is lost, the chance to preserve hearing are very bad and I would not do surgery to preserve hearing. So I would try to do something else, either Alzheimer's or something else. We'll discuss.
I mean, looking at the scans, the lateral extension isn't that great. So these look like tumors that, I mean, obviously we haven't got all the slices here, but it looks as, you know, as though these would be tumors that would be easier to preserve hearing potentially.
Yeah, but it depends on the consistency of the tumor.
Yeah,
also.
Exactly.
ABR is very important.
Gareth?
Now, the one thing that, you know, obviously you see papers written with 50%, you know, preservation rates. What sort of would you quote, Brad, to what sort of hearing preservation rate would you quote to this person or their parents?
On the right side, I think there's a 50-50 chance of preserving hearing and probably a 90% chance of saving a cochlear nerve. On the left side, I'd say there's probably a 30 or 40% chance of saving hearing and probably still a pretty good chance, 80% chance of saving the cochlear nerve, or maybe better than that. So I do think there's an opportunity. I agree with Michelle that an intact ABR is helpful. When you have a person with normal hearing and a normal ABR, it's hard to convince parents that that's something to consider, especially when the field's divided. I know Scott and I discuss patients like this all the time, and his feeling is better to wait and watch and hang on to their hearing as long as you can, then consider an ABI down the road.
The one thing you don't really hear that much, and I certainly know it from Manchester and our hearing preservation series, particularly the middle fossa ones, is the very high recurrence rate after surgery. And essentially you are saving the hearing, but then 10 years down the road, the hearing is lost because there is a new tumor or a recurrence of the original tumor that has grown. So what do you talk to your patients about recurrence rates when you do hearing preserving surgery?
It depends on the location of the tumor. If it's not jammed out laterally in the canal up next to the cochlea, there's a better chance of complete resection. But it may also be that you choose to do incomplete resection if you're doing direct eighth nerve monitoring and the cochlear nerve action potential starts to drop. You might choose to leave a little tumor. You've created more space for the tumor to grow. You may preserve their hearing longer than if you just let them, you know, if you say in 10 years, the tumor may be back, but if you don't take it out, the tumor is certainly going to be there in 10 years, and their hearing chances for long-term preservation is much worse. So I think that it depends really. If the tumor is really out far lateral and goes into the cochlea, there's no point in trying to preserve hearing. I would leave that one alone, and they probably would not have a normal APR at that point anyway.
Okay, so let's move on to Jayshree's got her hand in the air. Are we going to mention the word bevacizumab here?
No, but what I am going to mention is the counterpoint. And I just want to say that I think it's really important that we have these conversations about surgery as a multidisciplinary team for exactly what you're hearing, which is the point counterpoint. And so in our clinic, and just what you're hearing happens at Mass General, if somebody is referred to me, the next stop is neurootology and the next stop is neurosurgery. And we also consult radiation oncology early on, even though I almost never want that, but I want the person to have the full range. But I will, if I may, with deepest of respect to Dr. Welling, provide my counterpoints. which is that when I see our patients every 3 to 6 months for 20 years, there are several reasons to be concerned about early surgery. And the first is that it is one of many surgeries, and every surgery is a trauma. And if we are not certain, absolutely certain we're going to have benefit, then we have a responsibility to reduce the trauma. Even a perfect surgery with a perfect surgeon, the experience from a vestibular schwannoma or any skull-based surgery actually is quite jarring for the person who recovers from that, even when they recover fully. So if I'm thinking about a chessboard and I think about all of the potential surgeries that might be required, I try to limit how many surgeries total there will be. And so it depends not only the hearing evaluation that you already heard about, but where are the other tumors? Is there a huge thoracic meningioma? Is there some other major meningioma? Because we have a limited number of things that any human can be asked to tolerate. The second thing I want to say is, in my personal experience with our 145 people with NF2 that we're honored to take care of, I have never seen a cochlear nerve implant work better than partial open set. And that was after someone had the ability to go through a lot of training once it was placed. So most of the time, our patients are using that for sound awareness, but not for open set hearing. And they're using that in combination with lip reading or some form of either complete American Sign Language or some partial signaling. And so I want people to understand how it might work for them. And then the next thing I'll say is what Gareth already mentioned, that the nature of NF2, particularly knowing the subtype of the NF2 mutation, will influence my thinking. If this is a 14-year-old or 15-year-old with a truncating mutation, there will definitely be more tumors on that nerve. Maybe not a recurrence of the one that's resected, but additional tumors are coming in the next 4 decades. And how that will impact that person's function is hard for us to predict. And then, of course, the last thing that's hard for us to predict is we make a decision for surgery on one side to be hearing preservation surgery, 50-50 shot of that. And then we can't predict which ear will lose hearing. So then their other good ear goes out early and we have lost the ear that would have been functional, because the natural history is stochastic growth and a not linear relationship between hearing function and tumor size. That lack of predictability makes me very anxious to put anybody at early risk. So basically I take all of that into account, plus the 50% chance that they could have a good surgery with protection of hearing. And then I would say to a person in this situation, and maybe that protects us for 15 more years until the next tumor is big enough to worry about. Don't know. But I ask people to consider, if the worst possible outcomes happen with surgery, infection, no hearing, CI doesn't work or can't be placed, will we all be content that we made this decision? And this is the same as our current requirements from the NIH for consenting patients for clinical trials. We can no longer comment on the potential benefit. We have to say, if the worst things happen, will you have been at least at peace that you made these choices? So that's the counterpoint to early surgery.
Scott, do you want to mention the B word?
I certainly can. My quick comments were just to reinforce what Dr. Blakely was saying about the genetic severity score that your team at Manchester has developed, and how important that will be in our thinking about future prognosis. So I won't elaborate, but I completely agree that that's going to be something that we should be using more, and is a case to be made for getting comprehensive genetic analysis on all persons with NF2. In terms of bevacizumab, there is a lot of interest in seeing whether this is the right scenario. The pros of it, in favor of bevacizumab, could be this idea that 40% of persons that we've treated in our trials have had tumor shrinkage, another 40% have tumor stability, 20% continue to grow. But when you dig deeper into those numbers, you find out that both in the European series and in the American series, that it seems to be less effective for pediatric patients than adult patients. So the caution in this instance would be that at 15 years old, you probably can't quote the same numbers to this family that you would for overall. In addition, because treatment is prolonged and long-term, it always raises the question of how long you can manage a patient, without developing significant toxicity. I would say that in our program, we've moved away from treating these people early on in favor of trying new therapies that we'll be talking about later, at least initially. Doesn't mean that we wouldn't use bevacizumab, so I'm not saying we would never try it, but it may not be our first thing. And there is one question about the interaction between, can bevacizumab augment maybe hearing responses in individuals who have cochlear implants or other implants? That seems to be a question that was typed in. I don't know if that's been well studied. I might defer to Dr. Welling or Dr. Calamaridis to discuss that. I'm not aware of using bevacizumab to help function of implants. Does anyone, very briefly, since we have other cases, any comment on that?
I have not seen them used together, so I cannot comment. There was one other comment about a suboccipital approach, and certainly that would be the preferred approach on the left tumor. The right one, I would prefer middle fossa approach.
And just a word on cochlear implants. I'm not a neurologist, but I have some patients with cochlear implants, and I can call them by phone, so it works. When it works, it works.
Yeah.
So there are cases where it works really.
And our best ones are actually have been where there's been translabyrinthine removal. So you're deliberately destroying your ability to save hearing, but you then put in a cochlear implant and you get the best tumor, or the surgeons say they get the best tumor clearance from a translabyrinthine approach.
It's interesting. One of the factors that seems to deter from good cochlear implant function is if they have a functioning here on the other side. So the NF2 patients, as opposed to other scenarios where unilateral schwannoma patients always do better, in terms of hearing from cochlear implants, NF2 patients do better than unilateral patients do, because they usually have poor hearing in both ears.
Yeah. So very briefly, because we've already spent too long on this, but would anyone use radiotherapy in this situation?
Not right now, maybe later.
Well, there are many people around the world that would, but very few in complex NF2 teams. But we have data which is very worrying in terms of irradiating in childhood, and you're irradiating in a childhood predisposition syndrome. And we are seeing malignancies either within the tumor or elsewhere close to the tumor. For instance, a grade 3 meningioma that recently developed 15 years after radiotherapy in someone this age. So we do need to bear that in mind. I'm not saying we shouldn't treat at all with radiation, but certainly in this situation, I would be very wary of using it. So moving on, I think we need to do this a bit quicker. 45-year-old with a dead right ear, and the right side is growing very slowly. So this is your, this should be the left ear is the bigger one, sorry. So that should be we've got the tumors the wrong way around, but anyway, that's the left side. Assume that is the side that is, you've obviously got a meningioma there on the left side as well, but the ear is dead and it's growing slowly.
Actually, Gareth, if I may, in this person, the real life scenario is they have no functioning hearing on the right, where that tiny lesion is.
Where the tiny lesion is, right.
The word recognition score is under 20%, and the left has normal hearing, but is growing. This is a not uncommon scenario.
Yes, agreed.
Yeah, no, it is not uncommon that the worst hearing ear or the dead ear is the smaller tumor.
Right. Has the right ear been operated or not? Let's maybe for sake of discussion, let's say it hasn't. I mean, you can also use a cochlear implant through an intact schwannoma, even though it's got poor hearing. If it's got less than 20% discrimination, you might be able to put a cochlear implant in the right ear. And on the left ear, yeah, I mean, I can't tell. It looks like there's a little bit of brainstem compression, but if it's the best hearing ear, you'd certainly like to wait until there's significant more problem. I think you might consider Gamma knife for a tumor like this that's growing. I do think that the hearing preservation rate with Gamma knife is not very good, that over a 4 or 5 year period, they will likely lose the hearing in that ear as well. It doesn't look like it extends into the canal much though. And so it maybe there's hearing preservation possible with it, but it seems unlikely.
Maybe I'm misunderstanding, but I would offer that this is, in my opinion, a classic patient that would respond to bevacizumab in the sense that, if I understand correctly, the right ear is poor hearing, and I don't believe you're going to salvage serviceable hearing in an ear that has long-term scores that are low, particularly if you look at the PTAs. We could get into that, the pure tone averages. However, on the left side, if I understand Dr. Blakely correctly, the left side has good hearing with a growing tumor, and a reasonable goal would be to support that ear as long as possible. That is, to not apply radiation or surgery, both which have significant risks, of hearing loss, and try to preserve this patient's only hearing ear for a period. Is that I just want to make sure I'm getting the right scenario. Is that fair? So I would say, at least at Mass General, in a person like this, we might even be quick to choose bevacizumab over a new novel therapy such as bergatinib because of the proven benefit of hearing preservation or even hearing improvement and long-term safety for bevacizumab in a patient like this. And I'd be curious if others would first enroll to a clinical trial or first consider bevacizumab or another option.
And would you, if you've got a dead ear and the tumor is growing and you're not going to give a systemic therapy, would you take the tumor out because actually all it's going to do is get bigger? You've got a very good chance of facial nerve preservation and the tumor's gone. And would that be a scenario? I mean, Brad or Michelle, would you?
For me, I think that there are bilateral growth and hearing discussion. So it's, for me, a case for bevacizumab. No discussion.
Yeah, I agree. I don't think that this is a great candidate for surgery right now.
Okay, let's move on, because we're going to move into the sort of schwannomatosis scenario. So painful peripheral schwannoma on the median nerve, kindly produced by Alan. Alan could probably tell us what he did. So you can see in the middle of the upper arm, you can see an enhancing schwannoma in that bottom right image. So Alan, what would you do in schwannomatosis, or not even in schwannomatosis, in NF2? You do occasionally get painful peripheral nerve schwannomas.
So this patient had burning dysesthetic pain in the median nerve distribution in the hand, worked with the pain people, and eventually just said she couldn't really live with the pain anymore, but had no deficit, right? So she's nice and strong in her median nerve distribution, including the AIN. So once they fail non-operative measures, we go to surgery, and we quote the patient on something like this, a 2% chance of having a neurological deficit with surgery if it's taken out using a microsurgical approach.
Great. And Roz, would you definitely go for surgery in this situation?
Well, I would be very keen that I work very closely with a peripheral nerve surgeon, a neurophysiologist, and the pain unit. And I've seen somebody without Alan's skill operate on just such a tumor with rather devastating consequences. So I guess I would, with that sort of story in mind, that even if I decided clinically that there was no neurological deficit, I might be tempted to look at the neurophysiology before surgery. If I had a very superficial tumor that wasn't growing and intermittently painful, I might consider something local like lidocaine patches. But if as we too use dedicated peripheral nerve surgeons, I would defer to them, and if they were capable of taking out without deficit, and it was significantly painful, I would certainly consider that. But there are other options. And again, it just we can see a single tumor here, but it would really depend again if you had multiple lesions on that nerve.
I mean, it will obviously depend for this this poor lady, I think we said, as to how bad the pain is. But if you had a promising agent, clinical trial agent that is showing a pain response as well as potentially shrinking the tumor, is this someone you would consider for that trial?
Yes, I would. And again, it's very much, you might think about the patient, you want to think about their age. I mean, if you've got a violinist, you would be very keen to go ahead with perhaps a clinical trial, because a 2% risk by someone like Alan, that would be devastating for your career, for instance. So I think it is, if you cannot control it on reasonable pain results and you have a risk with surgery, that is certainly something to consider. But again, it depends, and Scott might have a view on this, how quickly this potential agent might work.
Yeah, I obviously we're very interested in, as many groups are, in these trials, and I think that in general, many of the drugs work within a period of days, weeks, occasionally months, and I think surgery, even though it does have low risk, of course, I would point out that it has low risk in the hands of very specialized surgeons. And one of the challenges in the United States has always been to try to get these patients into specialized surgeons. So a shout out to all the specialized surgeons who are doing this, where they're incredibly important in the care, of course. But a trial of drug is, of course, I think very reasonable in these individuals. I think one of the challenges is estimating benefit in these new trials, given the established placebo effect that we see in pain trials. So we're in the process in a randomized trial of trying to estimate, what individuals perceive as pain benefit, even not getting an active agent. And so I think the jury's a little bit out, and we hope to report on that in the coming months.
I think we better move on. Sorry.
Gareth, can I make one quick comment?
Yeah, of course. Alan.
So I operate on these tumors all the time, and yet I can tell you that I don't consider surgery until they have absolutely failed non-operative measures with a team. When I say a team, it's always Dr. Blakely who sees these patients, and the team works with them. And I think it's really important, although I'm very comfortable doing this surgery, I don't recommend the surgery until they have failed non-operative measures with a group that know what they're doing in terms of managing these patients. And that's really critical.
Yeah, I mean, in my experience, the one thing that is most likely to get rid of the pain on a permanent basis is surgery in schwannomatosis. But absolutely, if you're able to ameliorate things without, particularly on a nerve where there is a risk of causing significant loss of function, then you obviously have to weigh those together.
Yeah.
So this is a painful, slow-growing spinal tumor at T10, quite big. Michelle?
What do you mean by painful? You mean it's
causing back pain, quite significant pain.
If it's growing, I would say the risk is spinal cord compression and the pain. Yeah. So if you prove that it's growing, I would say, how old is the patient?
Well, let's say, for example, Jayshree provided the slide, but 40, shall we say?
Yes, 42.
The spine is really hardly compressed. So I would say if you show the growth, I would remove it. It should be not too difficult. It's T10, so there is no need to go outside, and the Adamkiewicz artery is not around. So I would say surgery, yes. It's not too risky. It's an easy surgery.
Did they have any other tumors, Jayshree?
This person does, not many and none other that are symptomatic, but I see where you're going, Dr. Ferner, and our conversation was, I think what this case brings up is the scans look terrible. Her exam is perfect, normal reflexes, normal sensory function, normal motor function, normal bowel and bladder, but a 42-year-old, so trajectory is another 30 years of life. There will be more growth, but we had lots of conversations about analgesic therapy first. And as Dr. Belsberg said, can we maximize that? And sometimes we just can't make life livable with the pain medicines. We can get them out of pain, but then they're not able to function in their normal capacities, which is another unacceptable situation. Or a clinical trial, this person, one of our issues is that we just haven't had a lot of access to clinical trials for schwannomatosis. Dr. Plotkin has done a beautiful job of getting them opened, but it's a big challenge getting companies interested, getting the grant funding. And so this person was interested in the trials and couldn't travel to participate.
Because I think the point that you make and that Michelle has made is that it's really important to know whether this is a growing tumor, because if you look at the axial images, it looks quite compressed. But as you've just pointed out, we can see people with really awful looking scans who are completely asymptomatic. So I think it's really important to know where you are on that sort of spectrum.
Yeah, and sometimes those tumors, we've seen tumor like this stay stable for 10 years or more, despite its size. So they do stop growing. And we do have to, that has to be part of the assessment. So if it's continuing to grow and it's like this, then it does force your hand somewhat. So, clinical trial might be an alternative, but again, that would have to be a team decision.
So it's important to understand why Michelle said this was a tumor that he would operate on. It's because it's sitting, if we think of dorsal and ventral, this tumor is nice dorsal to the spinal cord. So the access for the surgeon is straightforward and you don't need to go around the spinal cord to get it.
Yeah.
When the tumor is anterior, when it's more ventral, like in a neurofibroma, your risk on something like this would skyrocket in comparison.
Yeah, absolutely. Yeah.
So that's a really important thing here to understand why the surgeons would say, yeah, we'll go after this one if you feel it needs to be taken.
And the T10 nerve root isn't really very important in terms of what it supplies.
Yeah. And also, you're just above the thoracolumbar junction. So you would still do a laminoplasty and put the lamina back, but you're not going to disrupt the thoracolumbar junction. So this is favorable in all kinds of reasons for surgery.
Okay, let's move on because we're going to run out of time, although we did have quite a lot knocked off. So 2 centimeter frontal meningioma, 2 millimeter annual growth. Assume there's no other major tumor requiring treatment. Michelle, I guess that's you in the first instance.
How old is the patient?
28.
And I don't see in T2 there is edema or not?
No.
You can discuss radiosurgery or surgery, but for surgery you have time. So if you think about radiosurgery, it's now to discuss. For surgery, you can wait. So I would have the discussion with the patient. It's for me, it's asymptomatic, so it's, both options.
And frontal meningiomas can get quite big without causing any major issues.
So I would have a different approach, I think. First, I would note that there's significant bony hypertrophy here.
There is, yeah.
And so in the case of an isolated meningioma, which I think is different than we may talk about in a minute in a patient who might have multiple tumors where surgery is not as good an option. In this instance, I would again lean on my expert surgeons to consider a surgery in a young patient with a growing tumor. I think what this affords us, picking up on Dr. Calamari said, is I would tell the person, hey, in the next 12 to 24 months, I would do this. when's that going to work for you? Is it during the summer? Is it over Christmas break? But I would be preparing this person, because if you think of them at 40, this tumor is going to come out by the time they're 40 for sure. I would assume. I don't have all the imaging. So I would lean more towards surgery for the bony involvement and for the tumor, the isolated tumor, and just take it slowly.
I don't understand why for you, bony involvement change something in the discussion.
I think they become, it's a great question. So I've seen so many of these, they get through to the scalp. They invade all through the bone. And I think this person's going to have a lot of mass. So with radiation, first of all, you're not going to remove the tumor. You hope it might shrink, but it may not. And there's going to be significant mass effect on this person even after radiation. So I guess the reason I was mentioning the bony part was to say that would lead me, among other reasons, to favor surgery over radiation. That was what I was trying to say.
Yeah, for me, edema, in case of edema, I would do surgery without discussion.
Definitely.
Without edema, you can discuss this. Yes, 28, yes. Surgery is easy, so it's okay.
Do you want to mention brigatinib, Scott?
Sure, I'd love to. So just to refresh people's memory, so this is a 6-consortium site currently with Mass General, NYU, Johns Hopkins, University of Miami, Mayo Clinic, and UCLA, because I want to make sure we acknowledge everybody that's working on this trial, and looking at the multi-tyrosine kinase inhibitor brigatinib that Dr. Clapp mentioned initially. And so as background, this is a trial that's done in 2 stages. First stage is a trial design in which persons with progressive tumors of any type, including vestibular schwannoma, non-vestibular schwannoma, meningioma, and ependymoma, can be treated with brigatinib, because we don't know which tumor types might respond the best. And after treating 20 persons, looking at the data, which we call an interim analysis. So in this case, what I'll tell you now quickly is the results of the interim analysis, with an emphasis on the fact that this is not final analysis. Numbers do change, and I want to be very careful that this is a way of making decisions, but should not be viewed as the final data. But looking at this interim analysis and looking across all 4 tumor types, the results suggest that among the 20 initial participants who had 5 target tumors and 14 non-target tumors, that is a total of 18 or 19 meningiomas, we saw tumor shrinkage in about 28% of these tumors, slightly more than a quarter. And because this design is not directly comparable with previous designs, I want to just be careful to say it's not easy to extrapolate these results to any previously reported studies, but just to indicate that we have seen tumor shrinkage in about a quarter of tumors in persons treated with the drug. And we consider that to be very encouraging in terms of brigatinib for meningioma.
Yeah.
And so just the last thing, just to emphasize, because these are interim, the next 20 participants in the study will be enrolled both for persons who have growing meningiomas as well as non-vestibular schwannomas. And so the data I think we should all wait for before putting everybody on brigatinib is we should wait for the second stage to mature that data so that we get a better estimate of how many tumors can shrink on brigatinib. So the punchline is some early interesting data and some confirmatory data, which I hope will be available within about 12 to 18 months. I don't know, Jayshree, if you want to add to Dr. Blakely, if you want to add to that, feel free to, or Dr. Juvenile or anybody.
But I'll just add back to this case. This is somebody who I would refer to clinical trial. This is not the only meningioma. There are other meningiomas that are paraspinal, tiny, but this is a young person who will have growth of other lesions, asymptomatic. I'm not in favor of radiation for this lesion in a young person. I would be in favor of surgery if that's something she wished to do. But I think this is a perfect person for clinical trial because we have time to see effect.
I fully agree, Jayshree.
I thought this was the only tumor you said, the only meningioma.
No, I think I was trying to make it less complex. Jayshree is actually talking about the actual person who has this. The last scenario is an ependymoma, recent diagnosis, 2 centimeters in 2004, 62-year-old, you can see here, an ependymoma at sort of C2 level. There are many parts of the world with inexperienced or surgeons who are not experienced in NF2 that would see that lesion and say they need surgery, with the inherent very big risks that can occur with that. And you know, we had a recent patient who presented at the age of 82 with a reasonably large cervical ependymoma and tiny vestibular schwannomas, interestingly, a heterozygous variant carrier, so not mosaic. And he was basically killed by having surgery, which probably he should never have had, because he ended up basically tetraplegic from the surgery and never recovered. So I think really the take-home message is don't run in before you know what it's doing, because that's 20 years later and it's stable. So these tumors grow to a certain size and stop, but maybe I'll leave Michel to give the final word about which ependymomas he would operate on.
I would think about surgery in case of growing ependymoma. So if you can show the growth and before having too many symptoms, because if you do surgery in a patient with a deficit, motor deficit, the surgery will be a nightmare. So I would say do the surgery when it's growing, not too late, because you can never improve a patient by surgery. It's totally different with a spinal cord compression. So if you wait too much, there is no need for surgery, it's too late. So it's a balance for me. I don't know what is thinking Alan, but in this case, I wait and you see 20 years later, nothing. So maybe
Michel.
Alan Belsberg.
Michel, I agree 100% with you. You have to go in on that tumor when it's symptomatic early, but only when it's symptomatic. If it's not symptomatic, you would absolutely leave it alone. So growing or symptomatic, agreed.
And just as a cautionary tale, we encountered a teenager who, for reasons best known to the referring unit, got sent for proton beam for an ependymoma and did not survive.
Yeah, we've had several young patients who've been treated with radiation who've had massive acceleration in growth of their ependymomas and have died in relatively short time. So this is not a tumor in NF2 that I would say you should be irradiating. And we have had some very good responses in symptomatic tumors where the cyst is the tumor cyst is the predominant problem with bevacizumab, and some of those have been published as well.
But I have seen patients under bevacizumab for vestibular schwannoma with bulk growing tumor. The tumor were growing under bevacizumab. So I don't know if you have this experience.
No, I agree. I think the solid component parts doesn't respond. It's only the cyst that responds.
Sure.
Agreed.
Okay, well, that's the end of the scenarios. I think we've reached the end of our time as well. So thank you very much for the fantastic panel that's been put together. You've done a great job. And I think the important thing that we need to emphasize is that in most of these scenarios, we would want the ability to put these patients into good clinical trials, basket trials in the future if you know, the patients are eligible, so that we can get the next treatments for meningioma or ependymoma that hopefully will also work in schwannoma as well.
Gareth,
do I have? Sorry?
Gareth, I have one question. We still have a few minutes, so maybe what we could do is go around the panel and maybe that everybody gives a little concluding remark.
Okay, let's do that then. Let's so Scott, your concluding remark.
My apologies. My concluding remark would be a plea to refer patients to specialty centers with outstanding surgeons who commonly take care of patients with NF2. I think that is that remains the cornerstone of therapy. And I guess all in with the rest of the panel and others looking for clinical trials of drugs that can hopefully bend the curve in terms of quality of life and length of life.
Jayshree?
I will focus on clinical trials. I think that there is truly not a single person with NF2 who does not need to be on a clinical trial. Even if it's mild disease, there's going to be progression. And as Dr. Welling opened our session today saying, trying to move this problem out of the OR, we are completely dependent on our surgeons, and truly thank all gods that we have this amazing community. But we need to lower, like a good soccer team or football team, Gareth, we need to lower the shots that they have to save from the goal and just have less activity. So I just want to make a plea to anybody who has drugs or new ideas or whatever to bring them forward. We have the platform. We've enrolled 20 patients in 6 weeks, Scott. We have an amazing collaborative community, and we have real endpoints. So we can see efficacy or not very quickly. And I think we need to be putting all of our eggs in that basket. No pun intended for basket trials or Easter.
Right. Rosalie?
So I would like to just say for schwannomatosis that I think the paradigm for NF2 works for schwannomatosis, and that every decision, as we've shown with these patients, requires a multidisciplinary panel with particular emphasis on peripheral nerve surgeons as well as neurosurgeons, the pain unit and neurophysiologists. And one benefit of lockdown has been that there's been such an improvement in remote communications. And I can get an opinion from Scott or Jayshree almost as quickly as I can from Gareth. So thank you, everybody.
Thank you, Ros. Alan?
Yeah, so I think we're all echoing the same thing. We need more clinical trials. There's no question about that. It should be, medical treatment for these. From a surgeon's point of view, look, I love operating and I love doing these tumors, but there's no question the best thing as a surgeon is to be working in a multidisciplinary team. And I always say this jokingly, but I mean it. People ask me, what's my indication for surgery? My indication for surgery is when Dr. Blakely tells me to operate. That's when I know I'm supposed to operate. And not until she tells me to operate do I operate. And that's what I think is the best possible care for these patients.
And Michelle?
Yes, for me it's very different because I'm running the NF2 clinic. So I say to me, do surgery. So it's different. But I would say, I think that observation and understand the natural history remains something very important. I'm not in favor of proactive treatment because we see so many patients with, for example, gamma knife or surgery from the beginning. And I think that surgery remains a key treatment in NF2. So observation, surgery, and clinical trial and drugs. And bevacizumab is still a very good treatment because it's the only treatment that can improve hearing. So we have to keep this in mind.
So I think there was a question from Wade, which was, how do patients broadly get access to drugs? Scott or Jayshree?
Wade, can you clarify, do you mean in the clinical trial setting or do you mean off-label setting, just to make sure that we understand the question?
Yeah, in a clinical trial setting. I mean, to have a Northeast-focused clinical trials group is great if you live in the Northeast or if you live in Los Angeles or Miami. Patients that don't have resources, don't have money to travel. England's the size of Indiana geographically. It's a much different dynamic to have access to clinical trials in a country like the United States with a Northeast only focused clinical trial consortium.
I think these are very wise words and I thank you for them. I think We always try to have geographic coverage, but even in a perfect situation, we don't. I would just point out for those on the call, we do also have the Department of Defense sponsored clinical trial consortium that also runs NF2 trials, as well as multiple individual centers. It's also a challenge in other parts of the world, obviously, a lack of drugs. And I think as a community, and others can pipe in, we need to figure out ways of doing this. I think for rare conditions, we're never going to have the kind of penetration of clinical trials that we might have in more common conditions like breast cancer, stroke, and so forth. And so we have this inherent tension, whether we should look for travel funding or like we're looking into for schwannomatosis at Mass General now with Dr. Vanessa Merker and others. Can we do virtual trials? And what does a virtual clinical trial look for? We're very interested in this, expanding this option, given what Dr. Ferner said about how much we've changed. So I personally would look for novel trial designs to answer this question, but we don't have that answer yet in terms of the regulatory approval from the FDA.
So we'll just sort of finally finish with there are drugs in the pipeline. Jayshree's just mentioned that crizotinib is going into trial. There's an HDAC inhibitor trial in Europe that's potentially going ahead. There are anti-inflammatories, so there is evidence that growing tumors in NF2, schwannomas and meningiomas are very inflammatory, full of macrophages, that might be an approach, and that repurposed drugs might actually work in that setting. So we're very hopeful, and we'll probably hear more of that as we go further on. So I'll hand back to Patrice or to Annette to take us to the next session. And thank you very much, everyone.